Sabay-sabay tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana bilang ating sentenaryo, ay biglang natapos din. 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula na pakitang gilas sa loob ng PGH, may busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Ilang dekada bang tayo'y magkakasama? Sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating mithiin, karangalan at galing sa lahat ng ating gawain. Pagsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala't kwento natin ng katuwa at bighati, sa lahat ng pangyayari na naghubog sa atin. Tayo ang class ng 98, sa simula ng pakitang gilas sa loob ng PGH, may busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98, hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Yung medisina.
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary health care in the era of universal health care. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Magandang hapon, magandang araw sa lahat po ng nasa Zoom at sa lahat po ng nanonood sa Facebook at sa UP Manila live stream. Bago po tayo magpatuloy, hayaan niyo munang ipakilala ko po ang aking sarili. Ako po si Dr. Cesar Perez Jr., kasalukuyan pong isang Clinical Associate Professor ng UP College of Medicine. Ngayon po ako rin ang Training Officer ng Department of Ophthalmology and Visual Sciences sa PGH. Kasali rin po ako sa UP College of Medicine Class 1998, ang nagdiriwang po ng Silver Jubilee para sa taon na ito. Para sa araw po na to, isa pong karangalan na ipakilala ang ating tagapagsalita. Siya po ay suki na ng aming webinar, si Dr. Michael T. So kung hindi nyo pa po kilala si Dr. T sa ngayon, siya po ang aming pangulo ng aming klase. Siya rin po ang kasalukuyang Vice Chancellor for Planning and Development ng UP Manila. Isa rin po siyang professor sa Department of Physiology ng College of Medicine sa UP Manila. At siya po ay nagkiklinik ng kanyang specialization ng internal medicine, rheumatology na specialist sa mga ospital ng PGH, ng Manila Medical Center Manila, sa Manila Doctors Hospital at sa Asian Hospital and Medical Center. Sa ngayon po, sa araw po na ito, siya po ay magsasalita sa mga bagong aspeto ng rheumatoid arthritis. So ulit, maraming salamat Dr. T para po sa inyong lecture sa araw na to.
Magandang hapon, Cesar, at sa ating mga kasama. Ayusin ko lang yung aking slide. Time out. All right. Yan. At ako ay magsisimula ng mag-share ng aking screen. Oops. Yan. So, alam mo, sabi nga ni Cesar, siya ay ating training officer ng ophthalmology. Kaya naman ang aking title ngayon ay Eyeing Rheumatoid Arthritis in Resource Limited Setting. Payag ka ba dyan, Sar?
Ayos. Sige, tuloy na.
Ayos yan. Yan ang focus natin ngayon. Maraming salamat. Muli, ito na po ang aking huling webinar ngayong taon kasama ang aking mga kaklase sa UP Medical Alumni Society at gagamitin ko yung pagkakataon na to upang magpasalamat sa ating mga tagapagtangkilik. Ito ay isang revisiting RA na lecture. Ito po muna ang aking mga disclosures. Gaya ng nabanggit ko last Wednesday, nung ako rin ay nag-lecture tungkol naman sa osteoporosis. Ang objective Now, our objective will be to, at the end of this lecture, again, for our participants to diagnose rheumatoid arthritis, be able to treat DMARDs naive, low disease activity patients, be familiar with treatment-related conditions, and I'd like to take advantage of the presence of our classmates here, mga ophthalmologists, marami sa audience, but primarily of Cesar, who is an ophthalmologist with glaucoma specialization, so that we can monitor and treat ophthalmologic manifestations, and finally, escalate treatment. You might have seen this before. This is what rheumatoid arthritis is. It is a chronic inflammatory autoimmune disease which is associated with autoantibody to modified self-epitope, meaning rheumatoid factor positive or anti-CCP positive patients. These are the clinical manifestations. In A, you'll find synovitis, particularly of the proximal interphalangeal joint and the MCP. It is bilateral or symmetric in nature. In B, you'll also find a worsened hand with swelling of the MCP joint. And here on the fifth finger on the right is boutonniere deformity. C, you'll find almost a destroyed joint of the ankle. In D, you'll find minor erosions or periarticular osteoporosis, and E, you'll have erosions of the joint. Here, in letter F, you'll already find the worsened joint destruction. In G, the atlantoaxial joint is also affected in RA. And in H, you'll find some subcutaneous nodules. In 2010, the criteria for the diagnosis of rheumatoid arthritis was modified. It now has a scoring system where you can say a patient has RA if you score 6 to 10. This is the usual score, and you can find that here in mdcalc.com, ACR EULAR 2010 rheumatoid arthritis classification criteria. If you have a patient with more than 10 joints with at least one small joint affected, meaning swollen and tender, then you can give the patient a score of 5. If 4 to 10 with small joint affected, then you give a score of 3. And here, if you have a positive but low positive rheumatoid factor or anti-CCP, give 2. If high positive, give 3. An abnormal CRP and an abnormal ESR would be scored 1. And if the arthritis has been there for more than 6 weeks, then give the patient another score of 1. With that, you'll be able to at least classify a patient to have rheumatoid arthritis, and that will be easy. In 1997, we estimated that there will be about 180,000 rheumatoid arthritis patients in the Philippines, based on a prevalence of 0.17%. And when we characterize RA patients, we noted that there is female preponderance, 9:1, with a mean age of 49.44 years old, ranging from 20 to 78. In one of the LMLR or Lourdes Manahan lectures for rheumatology, I was able to differentiate in a discussion elderly onset versus young onset RA. Maybe you can just look at the YouTube of that lecture if you're interested. Aora versus Yora. Mean age of onset is 44.64, and the duration of illness prior to diagnosis is 5.4. That was then. I hope that because of this ongoing webinar and our attempt to educate our patients too on what rheumatoid arthritis is, the duration of illness prior to diagnosis will be shortened. Oops, there. The most common manifestation would be morning stiffness, arthritis, arthritis of the hand joint, and symmetric arthritis. Rheumatoid nodule is very rare. It's only about 11%, and X-ray findings is already high at 66.67%. And that reflects how much of a delay we have in terms of diagnosing. So that is something that we want to avoid. That's why the ACR EULAR 2010 criterion already excludes X-ray findings. Because if you have X-ray findings, you're already late. And you already have a patient who may be suffering from irreversible damage. So you don't want that. What we need to do now is to diagnose early and use that 2010 criterion. Five points for more than 10 joints, ESR elevated, rheumatoid factor positive, and more than 6 weeks. This is important because starting the year 2000, there is a major advance in the management of rheumatoid arthritis. Biologic agents became available. Note that in the early 20s, gold salt was the only drug available. And then in the 1940s, sulfasalazine became available. Antimalarials in the 1950s, steroids in the 1940s, and then methotrexate in 1980. The problem, this orange, biologic JAK, biologic leflunomide, they are still not PNDF approved in the Philippines, meaning our government cannot buy that. And so in a resource-limited setting, we have methotrexate, sulfasalazine, glucocorticoid. And that is a major limitation because access to drug becomes difficult. This is the EULAR recommendation. This is phase 1. Note this, phase 1 2019 update. If you diagnose a patient with rheumatoid arthritis, you can already start methotrexate if there is no contraindication. So here you'll note that methotrexate is the anchor drug. If there is contraindication to methotrexate, you can start leflunomide or sulfasalazine. Both you can combine with short-term glucocorticoid. And you just monitor for 3 months. If you achieve the target, then you just continue what you're doing. If not, you will have to go to phase 2. We'll discuss that later. But if it is, then you continue with dose reduction in sustained remission. Note here that methotrexate, glucocorticoid, sulfasalazine, and leflunomide are in the phase 1 of EULAR recommendation. This is ACR, or American College of Rheumatology. In DMARDs naive patients with low disease activity, meaning those with very few joints that are affected, the patient is not complaining so much pain, say, ang sakit-sakit ng katawan ko. Pag tinanong mo ng reklamo niya, 1 to 100, lagi niyang sasabihin, 100. Pagka ang sabi na ng pasyente, mga 20 na lang ho, ang reklamo ko, kumpara doon sa dating 100. O kaya sinabi niya na, yung dating 10 masasakit na daliri ko sa kamay, 2 na lang ngayon, o kaya 3 lang. So, that time, you will have a low disease activity. So sometimes patients will start complaining with just low disease activity. And if you catch them early, ibig sabihin nakapagpakuha ka ng rheumatoid factor, ESR, you might be able to treat with just hydroxychloroquine, sulfasalazine, methotrexate, or leflunomide. And this comes from the most recommended to the least recommended. This is how it is classified. DMARD's classification, conventional synthetic DMARD or disease-modifying anti-rheumatic drug would be those 4 FDA-approved drugs. Now, targeted synthetic DMARDs would include baricitinib, tofacitinib, or upadacitinib. These are JAK inhibitors. I have discussed that before and will not delve into that today. The biologic DMARDs would include anti-TNF and the non-TNF blockers like abatacept, rituximab, tocilizumab, and sarilumab. What is striking is that in the ACR 2021 recommendation, there is a very big focus on corticosteroid. Note that in the ACR EULAR, you can start with methotrexate, or you can start with leflunomide and sulfasalazine, with or without glucocorticoid. But the ACR says initiation of DMARDs without long-term steroid is better than giving it for longer-term glucocorticoid, meaning 3 months to longer than 3 months. And then saying that initiation of DMARDs without short-term steroid is better than initiating DMARDs with short-term steroids. Kung pwedeng wag ka na magbigay ng steroids, wag na. So una, sabi niya gano'n, kung pwedeng 3 buwan lang, 3 buwan. Kesa naman habaan mo pa ng 6 na buwan. Tapos sabi niya, kung moderate to high disease activity, bigyan mo ng maigsi, less than 3 months, kesa naman magbigay ka na. Pero kung pwedeng wala, wag na lang. So ito yun, initiation with short-term steroids. Ayaw niya yan. Sabi niya kung pwedeng wala na lang. Ngayon, ang pagdagdag or addition of or switching to DMARDs in patients that are taking glucocorticoids to remain a target is better than continuing steroids. So you have methotrexate and steroids. Rather than continue steroids, palitan mo na lang yung steroids. Gawin mo na lang na hydroxychloroquine siguro. Or start with methotrexate and sulfasalazine. Or methotrexate and leflunomide. Use combinations. But kung pwede, wag na lang steroids. Addition or switching to DMARDs with or without intra-articular steroids in patients taking DMARDs and not on target is conditionally recommended over the use of intra-articular glucocorticoid. Ayan ganun. Huwag ka na mag-inject. So in all of this, sinasabi niya, huwag nang mahaba. O sige, kung pwedeng wala, wala. Huwag mo na ituloy, o kaya huwag ka na mag-inject. Biro mo is one table dedicated to just discouraging rheumatologists from using glucocorticoid. Because this is the expert opinion on drug safety. Long-term side effects of glucocorticoid is a very long list. And I'm showing this to you because I've seen many patients receiving steroids, even for non-RA arthritis. Patients on gout who learned about dexamethasone from the neighbor would take dexamethasone and colchicine and not take allopurinol or febuxostat. Sasabihin, gumagaling naman dok eh. Yeah, gumagaling pero nagkaroon ka na ng tuberculosis o kaya nagkaroon ka na ng iba pa. Ano yung mga iba pa? Ito yon. Osteonecrosis and osteoporosis. Some of our patients would develop a vascular necrosis of the hip, meaning namamatay yung femoral head and they develop flattening of the femoral head and resulting pain that ultimately needs hip replacement. Myopathy, meaning muscle pain, just muscle pain, and weakness that cannot be attributed to other than steroid. Third is what most of us already know, hyperglycemia, diabetes, dyslipidemia, weight gain, moon fasces, adrenal suppression such that during surgery or in a stressful condition, they will have low blood pressure and growth suppression. Hypertension, coronary artery disease, ischemic heart disease, heart failure, and even sudden death have been associated with prolonged intake of glucocorticoid. If you look at the skin of patients taking glucocorticoid, you'll immediately recognize skin atrophy, ang ninipis ng balat, ecchymosis, erosion, striae, yung silvery striae that we always look for, yung parang may kamot sa tiyan kahit na lalaki at hindi naman nabuntis. Delayed wound healing, purpura, easy bruising, acne sa muka, and bacne sa likod. Hirsutism, nagkaroon na ng bigote, and hair loss. And this one, the last here in this slide, will be discussed later on by our glaucoma specialist, cataract and glaucoma. Minor mood changes to as bad as psychosis. This can happen among patients taking steroids. Yung delirium, we have seen that among patients on high-dose steroids we gave for SLE. And you know, the management is you double the steroids. Why? Just so you make sure that you're not dealing with SLE psychosis. And then if there's no improvement, you remove. Because treating SLE, neuropsychiatric manifestations of SLE is a priority over managing psychosis because of steroid. Now, let's define some terms. If we're going to treat patients for rheumatoid arthritis, we need to achieve remission. And there is a Boolean definition for that. Another would be low disease activity, meaning we use any validated disease activity scoring. I use DAS-28, which has a complicated calculation. But you can always use the internet to look for the sites where you just plug in a mannequin the joints that are tender, that are swollen, and then you ask the patients how he feels, 0 to 100, how bad do you feel, and ESR or CRP. Moderate to high disease activity according to any, again, validated composite disease activity measure. Now, treating, we know that we have three tablets that we can use in a resource-limited setting: sulfasalazine, methotrexate, and leflunomide, and corticosteroids. So what can be done will be DMARDs 1. If there is no response, add another DMARD. And there's no response, add another one. This can be a biologic DMARD. Some would say, give everything. Give everything forever, or give everything and then step down depending on the clinical response. This appears to be a combination of step up and step down. Is a combination that is frequently used by many societies recommending the treatment for rheumatoid arthritis. You step up, and when you achieve this triple therapy and then there is remission, you step down. Boolean remission is morning stiffness of less than 15 minutes, no fatigue, no joint pain. You ask the may masakit pa ba? Dok, wala na, parang bago na ako. Pag kinapa mo, there's no joint tenderness. Pagtingin mo talaga, walang masakit, walang namamaga, at normal ang ESR. In short, normal na normal yung pasyente. But then, sometimes this is achieved in a patient who has a combination steroid, methotrexate, and biologic agent. And I mentioned that in treating these patients, we have to be careful that we don't have side effects. There are many side effects. We already mentioned the side effects of steroids. We can mention about methotrexate side effects like hepatotoxicity. We can mention about TNF side effects like heart failure, increased susceptibility to tuberculosis, and for JAK inhibitor, maybe increased susceptibility to deep vein thrombosis and herpes zoster. But because Cesar Perez is our moderator, we will take advantage of his presence and talk about natural and iatrogenic ocular manifestations of RA. Possible drug-related. No, when I say possible, because there is really no marker to say it is the culprit. So we can just say it's a risk or a possibility. For glucocorticoid, there is posterior subcapsular cataract and open-angle glaucoma. Methotrexate, ischemic optic neuropathy, retinal wool spots, and orbital non-Hodgkin's lymphoma. Have I seen that? Yeah, retinal cotton wool spots. We have referred patients for eye problem and this came back. Leflunomide, punctate keratitis. This has been reported, but leflunomide was introduced in the Philippines in 2003, but was lost in the market maybe for 8 years, starting 2015. And it's only this year that it came back to the Philippines. And it is for this reason that I am now able to discuss a resource-limited setting type of discussion. Because now I can talk about methotrexate, sulfasalazine, and leflunomide because they are available. Unlike before, after methotrexate and steroids, hydroxychloroquine, I can only talk about biologic agents like infliximab, tofacitinib for JAK inhibitor, golimumab. But now, we can talk about this freely and say, if we give this, and you give hydroxychloroquine, you'll have vortex keratopathy to bullseye maculopathy. This has been reported, but for the many patients, up to 90% of patients receiving with SLE are receiving hydroxychloroquine, it is a very rare condition. But still, when it happens, it is a possible drug-related ophthalmologic condition. Tofacitinib, as a JAK inhibitor, is associated with herpes zoster virus infection. TNF inhibitor is paradoxically, we say paradoxically because patients with uveitis are treated with anti-TNF. And now you have patients without uveitis developing uveitis after being treated with TNF inhibitor. Tocilizumab, a drug that became popular for treatment of COVID-19, is associated with recurrent episode of PUK, multiple cotton wool spots, and retinal hemorrhages. While rituximab, a drug for lymphoma, also a drug for SLE nephritis, although it's not really FDA approved for that purpose, is associated with necrotizing scleritis, macular edema, and visual impairment. So now we go back to this. Hydroxychloroquine, sulfasalazine, methotrexate, and leflunomide. We can give these. These are all available. And it is time to discuss a systematic review and meta-analysis on the efficacy and safety of leflunomide and methotrexate in the treatment of RA. Here you have 1,971 identified database articles with 70 records screened and then 6 studies included in the analysis. Panel A, this one is Panel A, has 6 studies which looks at achievement of ACR20. ACR20 means from an original count, you have 20% less swollen joint, tender joint, a physician global assessment, ESR is also 20% lower, and patient assessment is also 20% lower. From initial na 80, let's say 80, I am 80%, I feel 80% bad. Now only 63. Then that's achievement of 20% improvement. Here you'll note that there is improvement that favors methotrexate rather than leflunomide. In the swollen joint count, again, it's methotrexate that is better than leflunomide. And here, also in tender joint, it's a tie. No, you cannot choose between leflunomide and methotrexate. So here we're saying leflunomide and methotrexate are almost the same when it comes to efficacy, but for safety, there are findings that leflunomide is more associated with hepatic transaminitis. So again, we have discussed leflunomide and methotrexate. Let's talk about sulfasalazine. I'm excited to talk about sulfasalazine because ever since I started training until this year, there's no available sulfasalazine in the Philippines. Yes, zero. Except from those manaka-naka na nabibili ng pasyente sa Hong Kong, and they're able to get it from our OFWs who are willing to send the drug from Hong Kong to Manila or from other countries. So some patients are able to buy them and most cannot. So this one is a Cochrane study where we have at most 256 participants in combined studies, 6 studies, looking at the OMERAC. This is an old study because no one studies sulfasalazine anymore. This is already an accepted drug for the management of RA. So tender joints, number of swollen joints, pain, physician global assessment, patient global assessment, functional status, CSR. This 9 was collapsed into ACR 20, ACR 50, and ACR 70, and DAS 28. So meaning this predated the ACR's classification. And this is the findings. Analysis in terms of tender joint, you'll see that sulfasalazine is better at an odds ratio of minus 2.45 compared to placebo. Sulfasalazine versus placebo outcome on swollen joint, minus 2.38. Note that it's still using placebo because then during this time, there is no prohibition from using placebo because there is no standard of care yet. Now you cannot give that. You have to give standard of care. Here, for the outcome of pain, again, minus 8.71 for sulfasalazine compared to placebo. And the physician global assessment, slightly favors sulfasalazine, and for this outcome on patient global assessment, again favors sulfasalazine. So with this 5 outcome measures, we gain confidence that out of these 6 studies, we can say that the use of sulfasalazine is well documented and well supported by evidence. But when we are not in a resource-limited setting, and in the phase 2, your patients do not achieve good outcome, and there are poor prognostic factors present, meaning rheumatoid factors and ACPA are at high levels, there's high disease activity, then you have to consider biologic DMARDs. And to consider that, and we want to learn more about that, just look at our files in the management of rheumatoid arthritis we delivered in 2022. And still, those are valid because there's no additional medications that have been made available here in the Philippines. Poor prognostic factors are absent, then you just add a second DMARD. Meaning if you're on methotrexate and steroids, you add leflunomide, sulfasalazine, or any combination plus steroids. If that improves, then you taper. If there is no improvement, again, in a patient with poor prognostic factor, then you go to third phase. But to know really what is a list of poor prognostic factor, these are the poor prognostic factors. Despite treatment, you have more moderate to high disease activity, high ESR, high swollen joints, rheumatoid factors are high, presence of early erosions, and failure of 2 or more DMARDs. Glucocorticoids should be less than 7.5, and tapering is defined as reduction of drug or increase of application interval. Meaning, if you're giving the drug, the biologic, no, let's say it's every 2 months, and you're able to give every 3 months, then that is tapering already. And that's a common practice that's reported by our colleagues from India and Pakistan. So may include also cessation or tapering of steroids so that you can say that you achieve steroid-free treatment. And now, if there is really no improvement, then you just change or cycle. This morning, I was lecturing to my fellow on cycling and switching of biologic agents for patients with psoriatic arthritis. In psoriatic arthritis, what you do is from anti-TNF, you go to IL-17, IL-12-23. But in RA, there is good evidence that you can actually switch within class. So that is phase 2. But phase 3, now you have to change. You have to cycle. I mean, the first one is cycle from anti-TNF infliximab to golimumab to adalimumab. These are all anti-TNF. And then if there is failure, you can go to cycling, switching biologic DMARDs. And then look for improvement, continue, or dose reduce. So in essence, you have these 3 phases. You try the low disease activity using tablets. If there is improvement, you just taper because you know that there are several iatrogenic manifestations or side effects to drugs that we are giving. And we were able to discuss that. And maybe for the next few minutes, we'll allow our moderator to further teach us how to avoid them. So with that, I hope I was able to discuss rheumatoid arthritis management in resource-limited setting. Thank you and good afternoon.
Salamat, Mike, sa palaging napakaraming information na ibinabahagi mo sa mga tagapakinig ng webinar natin. Merong mga tanong sa chat box, baka may pagkakataong kang sagutin yung ilan, Mike. Yung iba medyo na banggit mo naman dun sa lecture mo. Kung halimbawa daw, may mga lagpas 1 taon nang may ginagamit na gamot, hindi responsive, kung magpapalit daw sa ibang gamot, ano yung mga ibang side effects. Yung iba doon, nabanggit ko na. Halimbawa, DMARD, maglilipat ng methotrexate.
Yeah, i-elaborate natin yan. Can a conventional DMARD be given for more than 1 year to those who are non-responsive to methotrexate? Yes, we can give. But if it's non-responsive yet, maybe the dose is low. So, ang strategy dyan, dagdagan mo muna yung usual na 5 tableta na binibigay hanggang makaabot ka kahit na 7 tabletang methotrexate 1 linggo. Kung hindi pa rin, at hindi naman kaya ng pasyenteng maka-afford ng iba, try mo yung injectable para mag-improve ang bioavailability ng higher dose. You can add steroids, yun nga, sana hindi, pero kung kailangan talaga, i-add. Meron ding pagkakataon na ngayon na magdagdag na tayo ng sulfasalazine. Sulfasalazine is usually given at 2 grams per day. Available yan ng 500 milligrams. So, pwede nating dagdagan ng additional DMARDs at kapag na-achieve na natin yung ating target, bawasan na. Dahan-dahang bawasan. Siguro, una kong babawasan dyan, yung methotrexate na hindi naman naging effective. Pero, kailangan mo talaga siyang ibigay na combination. Try mo muna yon. Kaya lang, kung yung pasyente talagang kaya naman, magbibigay na ako ng anti-TNF.
Salamat, Mike. Sige, bago ko basahin pa yung ibang mga tanong, hayaan mo munang pasalamatan natin ang ating sponsor para sa webinar na to, ang ah, Med Infinity. Okay, sila ang sponsor para sa webinar na ngayon. Meron pang isang interesting na tanong eh. Halimbawa, yung mga paggamit daw ng pain remedies, no, NSAIDs, COX-2 inhibitors,
Oo.
pang-control lang daw ng sakit pero hindi talaga natutugunan yung pinagmumulan ng problema. So, dahil doon tuloy, medyo hindi maganda rin yung gamutan. Ano bang mababanggit mo tungkol doon sa pag-iisip na gano'n?
Oh, madalas yan, yung nagbibigay lang ng NSAID, no? Tama yan. Laging tama yan sa umpisa. Dahil yung pasyente, pupunta sa'yo na may pain. So, gamutin mo yung pain. Pwede ka magbigay ng NSAID, pwede ka magbigay ng tramadol in combination with steroids kung talagang naniniwala ka na na-inflammatory yan. Pero dapat kapag ka na-diagnose mo na meron siyang RA, psoriatic arthritis, you go for that actual treatment. Hindi mo pwedeng bigyan lang ng pain reliever. Tama na magbigay ng pain reliever because makataong gawain yan eh. Hindi mo naman pwedeng hayaan na nananakit yung pasyente at sabihin mo, hindi ka dapat uminom ng pain reliever, reliever lang yan. So bibigyan natin siya with a warning. Kung ikaw ay mahigit ng 60 taon at umiinom ka ng aspirin o kaya nakainom ka ng warfarin, ay malamang duduguin ang tiyan mo. 15% ang tsansa na ikaw ay duguin ng tiyan kapag ka ganun ang classification mo. May mga pasyente na umiinom na nga ng steroid, umiinom pa ng NSAID. Mas malaki rin yung tsansa na sila ay magkaroon ng sakit sa tiyan. Una yon na side effect. Pangalawa, kung palaging umiinom ng NSAID, maaari ring maapektuhan ng bato. And we have to warn them also about that. So when we give these medications, we have to tell them, you have to take this short term. Siguraduhin na natin itong laboratory na pinagagawa ko sa iyo ay magawa mo. Ibalik mo sa akin to sa lalong madaling panahon para mabigyan kita ng gamot. Ano ba yung common na laboratory hingin ko kung meron akong inisip na inflammatory arthritis? Una, ESR. Kasi kung yung ESR ay negative, naka-decline ko lang to. Kasi kung yung ESR ay negative, malamang hindi yan inflammatory arthritis. I will continue to give the pain reliever until the pain is resolved. Kasi yun lang ang pwede mo ibigay. But if the ESR and CRP are positive, then it tells you there's inflammation. Ano yun? Well, pwede pa ring infection, di ba? Yung kung isa lang yan, pwedeng TB yan na mataas ang inflammation. So, dyan naman papasok yung meron bang morning stiffness, meron bang pamamaga na nakikita ka. And then, we will know. So, ESR, CRP. Next, if I think of a bilateral polyarthritis, chronic, I'll ask for rheumatoid factor and anti-CCP. Kung may rashes, I'll add anti-nuclear antibody. And then we'll be able to diagnose. Within the next week, you will already know the kind of treatment you need to give the patient. So yan ang gagawin. To avoid the long-term intake of NSAID and steroids.
Salamat, Mike. Meron pa dito yung iba daw na mga nasa probinsya, very much underdiagnosed ang RA. So, medyo mas marami-rami pa yata tayong kailangang
I-webinar.
gawin. Yes, para mas madagdagan yung kaalaman nga ng ating mga healthcare providers lalo na sa probinsya. So sana may mga nakukuha silang mga impormasyon para lalong mas maintindihan yung kalagayan ng RA. Meron pang mga nagtatanong na home remedies, no? Nagbanggit ka ng mga gamot sana na makakatulong sa mga pasyenteng may RA, pero hindi natin may iwasan na mga pasyente na mag-iisip pa rin ng mga kakaibang paggamot. So, may mababanggit ka ba na makakatulong pansamantala bago sila gumawa o bumili ng mga nabanggit mo ng gamot? Halimbawa, yung mga simpleng home remedies, kung meron. Kung wala, edi talagang yun.
common na kapag may namamaga, pwede natin lagyan ng ice pack, no? Madali yon. Pero I would not advise intake of unsupervised, lalo na yung mga herbal medicines na pinakuluan mo mag-isa kasi hindi mo alam kung gaano karaming dahon ng pakukuluan mo, gaano katagal mo yung pakukuluan at kapag ininom mo, ano pang ibang mga impurities ang nainom mo that may result to side effects katulad ng sirang bato. Marami ng ganyan, nasira ang bato kakainom ng kung ano-anong gamot at talagang kung hindi mo alam ang iinumin, mabuti pang magpakonsulta na sa doktor. And siguro marami naman tayong available na video sa UP College of Medicine Medical Alumni, sa UP Medical Alumni Society last year, 2 years ago ng iba't iba nating mga doktor. So yung ating mga general practitioners, ang ating mga primary care partners, pwede pong panoorin yon. Pwede nyo namang i-times 2 kapag masyadong mabagal yung nagsasalita at i-times 2 mo na lang, matututunan mo. Alam nyo, minsan nanonood ako ng mga webinars ng aking mga kaklase para rin matuto sa kanilang field of specialty. And this is a service that we really want to do. We have a library for this and take advantage para alam nyo kung anong request ang gagawin.
Ito siguro mga pahuling tanong bago ako magbanggit ng mga eye findings. Yung mga gamot na nabanggit mo, Mike, meron bang taning kung gaano katagal? 1 taon ba kailangang hintayin o mas mababa ba sa 1 taon? Ano ba yung basihan para pwedeng ituloy o itigil? Meron bang timetable o yung sintomas na nakikita sa pasyente talaga yung basihan?
Kung bumuti yung kalagayan ng pasyente, tuloy mo yung gamot until makakita ka ng side effect. Kaya ka nagmo-monitor, halimbawa ng AST/ALT, para alam mo kung nakakasama sa atay ang iyong binibigay na gamot. Ang ESR, minomonitor din para alam mo naman kung nahihit mo yung target. Kasi sasabihin ng pasyente mo, maganda ang pakiramdam niya, bumubuti ang kanyang mga joints, pero mataas pa ang ESR, hindi ka pwede magtanggal ng gamot. Kasi pagtanggal mo nun, mag-flare yan. Sasama ulit yung kalagayan ng pasyente. So dalawa yan. Side effects, efficacy. Kailangan balansyado, wala kang side effects, at na-achieve mo yung efficacy na kailangan. At bigyan mo ng konting panahon, sabihin natin 3 hanggang 6 na buwan bago mo pakialaman ulit yung gamot. Sabi mo, maganda na, so bawasan mo. At pag nagbawas ka, dahan-dahan. Hindi mo pwedeng i-withdraw ang DMARDs. Talagang hindi. Dahil kapag winidraw mo yan, babalik lang yung sakit. Para kang nagtanggal ng gamot sa diabetes dahil nakuha mo na yung HbA1c na 5, 5.5. Pagtanggal mo niyan, tapos konting kaya ng pasyente, akyat yan ulit sa 9. Kamot ulo ka na lang. Oops, paano kaya to? Magagalit yung pasyente. Sabihin niya, walang nangyari. So, para din yan yung mga pasyenteng may gout. Matapos gumaling yung kanilang rheuma for 1 year or 2 years, nakalimutan na, papaalala na lang ng rheuma na masakit yan kapag tinigil na yung gamot nila na allopurinol or febuxostat.
So kanina nabanggit ni Dr. Tino, ni Mike, na yung rheumatoid arthritis may mga side effects sa mata at yung mga gamot meron ding side effect sa mata. Okay? So ang kailangan lang naman nating tandaan yung sakit na rheumatoid arthritis na banggit ni Dr. T, kadalasan autoimmune siya. So halos maraming parte sa katawan talaga yung maapektuhan. Kasama lang po yung mata. So sa mga primary care health workers na nag-aalaga ng mga pasyente na may rheumatoid arthritis, isama nyo lang po yung paningin kung meron pong mga kakayahan na magbasa dun sa mga vision charts, mas maganda po. Kung wala naman po, i-check din yung kulay, lalo na yung kulay pula. Okay? So yung pinakapag-aseso po ng kulay, isa sa mga unang pagbabago po yan sa paningin, lalo na kung medyo matagal na yung rheumatoid arthritis. Ang epekto kasi po ng rheumatoid arthritis sa mata, medyo madami-dami hanggang sa harap ng mata, hanggang sa pinakalikuran. Medyo mahirap kung ma-assess ng biglaan, mas maganda po na makita talaga po ng specialista na may malapit sa inyo kung may kakayanan. Lalo na po kung ang idinadaing ng mga pasyente is paningin na lumalabo, nagbabago nga po yung kulay, nagiging mas malamlam, no? Yung kulay pula, nagiging pink. Okay? Hindi na kasing tingkad ng kulay na pula yung nakikita ng pasyente. Mga maagang pagbabago po yan sa paningin ng pasyente. Mga guhit na hindi na diretso, no? Parang lumiliko o parang kumikembot, no? Yung mga linya, mga importanteng mga impormasyon na kailangang makuha sa mga pasyente na may rheumatoid arthritis. Ngayon naman po dun sa gamot. So nagbanggit si Dr. T ng napakaraming gamot para makontrol yung rheumatoid arthritis. Hindi naman po lahat, no? Merong side effects, pero meron po kasing mga gamot na kailangang binabantayan po yung paningin. Kung magsisimula tayo dun sa methotrexate po kasi ang talagang nagkakaroon ng epekto maliban sa harap ho, no, yung pinakaloob nga ng mata, yung tinatawag namin na retina. Kaya po yung mga rheumatologist bago po kadalasan magpa-simula ng gamot, pinapa-refer muna po nila, pinapakita po nila, pinapasuri yung loob ng mata, no, sa mga espesyalista para lang po sigurado. Maliban kasi po dun sa methotrexate, pati po dun sa hydroxychloroquine. Ang epekto po nila kadalasan ay nasa retina, nasa loob po ng mata. So hindi po siya nakikita dito sa harap, nandun po sa loob. So hindi po basta-basta nakikita. So pag nasuri po yun ng specialista at may nakita po na malamang po magkakaroon ng paglala, no, nung kalagayan ng retina ng pasyente, kailangang malaman po yun ng specialista na rheumatologist. At ang hindi pa po dun kasi maganda, kapag may nagbago po sa retina ng pasyente, kadalasan po yun ay permanente. So hindi po rin halimbawa nasimulan yung gamot, inalis, babalik po ulit na malinaw na agad yung paningin. So napaka-importante po, no? Napakahalaga yung koordinasyon po nung rheumatologist at ng specialista sa mata para po mas kabuuan, no, yung pag-aalaga doon sa pasyente. Nakontrol nga po yung rheumatoid arthritis, nabulag naman yung pasyente. So parang baliwala rin po yung pag-aalaga doon sa pasyente. So kadalasan po pag sa may steroid naman, kanina nagbanggit si Dr. T sa glaucoma, sa catarata, hindi rin naman po lahat nagkakaroon. Kaya lang kadalasan nga po ng mga may rheumatoid arthritis ay may edad, no? Nabanggit ni Dr. T, halos senior, tapos karamihan mga kababaihan. So yung katarata po ganun din naman. Kaya lang nagpapabilis po, no, ang pagdevelop ng katarata kapag meron pong iniinom na steroid ang mga pasyente. So hindi po lahat nagkakaroon lang ng pagbilis ng development. So yun po talagang paglabo naman ang babanggitin ng mga pasyente. Glaucoma po sa umpisa, walang sintomas, walang masakit, walang malabo. Pero po na-assess, na susuri ng mga espesyalista sa mata yung glaucoma kapag nagpatingin, yun din po ay naapektuhan ng steroid. So sa mga umiinom po ng steroid na mga pasyente na may rheumatoid arthritis, kung halimbawa po mapapacheck mga kada 3 o 6 na buwan, lalo na po sa umpisa, no? Mas maganda po para lang masuri, mabantayan yung mga tinatawag na side effects ng gamot. Hindi po lahat nagkakaroon, pero kung halimbawa kasi magkaroon, baka permanente yung epekto. So mas maganda po na nasusuri. Hindi rin po lahat ng may rheumatoid arthritis meron pong kaakibat na epekto sa mata. So halimbawa po, may mga pag-aaral, mga 20 to 40% lang po ng may rheumatoid arthritis yung may finding sa mata. Importante pa rin po na ma-check yung kabuuan, lalo na yung mga mahina yung puso, no, yung mga may high blood, yung may mga sakit sa puso. Yun yung mas importante na tutukan maliban po din sa mata. Ayan Mike, ano pa ang madadagdag natin bago tayo magtapos?
Salamat, Sir. Wala na tayong oras at
Nga nga eh.
salamat sa iyong dagdag na lecture. Alam nyo, napag-usapan lang namin kanina ni Cesar to eh. Sabi ko, oo nga no, pwede nating baguhin yung lecture. Kaya mula alas 10 hanggang alas 11:55, binabago ko yung lecture ko para masabi natin na ma-take advantage natin. Ang galing ni Cesar dito na take advantage ko sa clinic dahil kapag may nakikita akong pasyenteng may RA at nagreklamo ng konti sa mata, naipapadala naman kay Cesar. So, salamat sa inyong lahat. Salamat sa aking mga kaklase sa patuloy nating ginagawang ganito sa webinar. At sa mga tagapagtangkilik na ng Knowledge Unlock, magandang hapon po sa inyong lahat at sana makatulong kami sa inyong regular na practice as physicians, as healthcare workers. Yan po ang ating aim at dadagdagan pa ho namin sa susunod na ilang mga panahon ng mga webinar library natin at we will make them available to all of you. Maraming salamat.
Bago po tayo
At magpapasalamat
magpatuloy,
pa pala ako
yan,
kay Orange
yan.
at kay
Oo.
Dennis.
Teka Mike, ito na yung ano mo,
Lagi nating kasama.
certificate mo.
Ha?
Okay? Para sa iyong
Oh, thank you.
lecture para sa ngayong araw na to. Maraming salamat sa oras at mga ginawa mong paglilinaw no tungkol dito sa webinar natin. So yan po ang kanyang certificate at bago po tayo magtapos, nagpapasalamat din po ang aming klase ng 1998 para po sa mga tumulong para sa webinar po na ito. Unang-una po ang University of the Philippines, Manila, ang UP Medical Alumni Society, ang Postgraduate Institute of Medicine, ang UP Information Management Service, at ang atin pong sponsor para sa ngayong araw na to ang Med Infinity. Malugod po naming inaanyayahan at iniimbitahan ulit ang mga tagapagtangkilik ng webinar natin para po sa susunod. Ito po ay may pamagat na Mathematics of Transmission. Ito po ay tungkol sa COVID-19 at ang ating tagapagsalita ay medyo sikat po, no? Siya, lagi po natin siyang nakikita dun sa kasagsagan ng COVID. Si Dr. Guido David, isa pong professor sa UP Diliman, director po ng Diliman AI, at fellow po no, ng Okta Research. Ito po ay sa ika-27 ng Oktubre, sa Biyernes na po. Okay? Alas 12 rin po ng tanghali at pwede rin pong gamitin yung ating Zoom link para po magrehistro ng mas maaga o yung ating QR code na pinapakita po sa screen sa ngayon. At para po matanggap ang inyong attendance certificate, pakisagutan lang po yung evaluation form na makukuha po dito sa QR code. Ilalagay din po sa URL, no, sa chat box kung hindi po nyo ma-access yung QR code po. Kailangan nyo pong sagutan yung evaluation form, kailangan pong masiguro na ang ilalagay nyong pangalan ayun yung gusto nyong lumabas po doon sa sertipiko na inyong matatanggap. So, ulit po, maraming salamat sa patuloy na pakikinig, pagtangkilik sa webinar para po mapagpatuloy natin na ma-unlock no, yung knowledge, lalo na po sa ating mga primary care physicians, workers at allied medical professionals. Maraming salamat po. Namaste. Magandang araw po sa lahat.